Presenting a case of bilateral isolated atelectasis palsy. Abducens nerve palsy is seen as a false localizing sign in patients with raised ICP of any reason, but isolated abducens nerve palsies associated with intracranial aneurysms have rarely been reported. Proposed mechanisms for bilateral abducens nerve palsy associated with subarachnoid hemorrhage include direct compression of the bilateral abducens nerves, vasospasm of the pontine branches of basilar artery, and hydrocephalus. Spontaneous recovery rate is in unilateral palsy is 12 to 73% in 6 months with a median time of 90 days. The predictors for non-recovery may include complete palsy and bilateral palsy. Surgery is currently indicated in those who have not recovered within 6 months to 1 year after injury. The success rate of the surgeries range from 30 to 80%. Coming to the case report, a 21-year-old male presented with double vision since 8 months associated with limitation of movements of both eyes. Patient also complains of inward deviation of both eyes. Patient gives history of road traffic accident 8 months back and sustained head injury and was diagnosed as bilateral temporal lobe contusion with subarachnoid hemorrhage. Patient was in coma for a week and underwent decompressive craniotomy for the same, following which patient gives ocular complaints. On examination, patient had face tilt to the left side and esotropia more than 45 degrees on the left side. Anti-segment of both eyes were normal and squint examination revealed greater than 45 degrees of esotropia with nystagmus on attempted abduction. So this was the position of eyes on all the cardinal gazes. Pupil was reactive to light in right eye while there was relative afferent pupillary defect in left eye. Dilated indirect ophthalmoscopy revealed normal fundus in right eye and pale disc in left eye. So the extraocular movements, the right eye dextro elevation, dextro depression and this were restricted similarly in left eye. The management options, that occlusion of one eye to elevate the diplopia, which was given as an interim measure for this patient. Prism lenses to elevate diplopia and botulinum toxin. Patient was not accepting this, so we went. Next option is surgery, which is medial rectus resection. So initially we'll do force generation test. So if it is positive, it shows there is paresis, that there is at least some power in the lateral rectus muscle, so we can go ahead with lateral rectus resection. Or if it is negative, that shows that there is palsy of the lateral rectus muscle, so we will go ahead with medial rectus resection. So this patient underwent both eye medial rectus resection under local anesthesia. So this is the post-operative images in all cardinal cases following the both eye medial rectus resection. So isolated loss of lateral gaze with no other cranial nerve signs, no pyramidal tract signs, and no signs of muscular entrapment is thought to result from an injury to the peripheral nerve along its course from the brain stem to the lateral rectus. Bilateral palsy is extremely rare and is thought to indicate severe trauma to the head and neck, and the appropriate high index of suspicion for associated injuries must be maintained. Spontaneous recovery may occur in 6 to 12 months, but surgery may be indicated if patient doesn't recover in this time period. Since spontaneous recovery is possible in 6 to 12 months, referral to ophthalmology of such patients is recommended with close observation for 6 to 12 months. Non-surgical options in the interim period include occlusion therapy, prisms, and botulinum injections. Surgery can be planned for such patients if spontaneous recovery doesn't occur in this time period. Some references.
Thank you. Interesting presentation. Only few things I want to say. One is that this is traumatic, post-traumatic fixed nerve palsy.
Yes, sir.
And these are not likely to completely recover. Other
Yes,
thing I
sir.
think which you have missed out something like you did not do any temporal bone CT to see if there is any fracture in the temporal bone, because quite often if you have bilateral
Yes, sir.
ones, they are likely to have a fracture in the temporal bone along with the facial can also be damaged in some of those cases because
Yes,
they
sir.
are lying close by.
Yes,
And
sir.
as sixth nerve is ascending up the petrous part of the temporal bone,
Yes, sir.
so that part you should have done, I think, which you did not do. CT must have been done, I'm sure, because
Yes,
you
sir.
were in coma for quite some time.
Yes, sir. That time CT was done. There was only contusion and hemorrhage. There was no fractures, sir.
So probably they have not. You have to do CT temporal bone.
Temporal bone, sir.
If that has not been done, it can be missed. Probably because bilateral one not recovered, so there should have been some actual injury to the nerve.
Yes, sir.
Other thing is that by 6 months or 8 months it didn't recover. Was there any recovery or there was no recovery?
There was none.
There was no recovery. And post-operative test was positive.
Yes, sir.
Because the point is, even after surgery,
Yes.
you did not have much improvement in the
Yes.
system. So there are two things. One is the paresis part, other is the contracture parts, and both parts have to be taken into consideration. Maybe with the MR session you have taken care of contracture part, but for paresis part you have to do some kind of transposition. Maybe because that's why you don't find any much improvement in abduction. So there is some improvement in the angle of the vision, but still there is something needs to be done. Other thing to be kept in mind is whenever you have a bilateral palsy, you must Yes, go ahead, doctor.
So good morning everyone. Today I'm going to talk about total muscle transplantation procedure for a large angle deviation. No financial disclosure. So the purpose of this paper is to demonstrate the effectiveness of total muscle transplantation procedure as a primary surgical procedure in case of large angle deviation. It's a case-based study with 3 patients having large deviation more than 70 PD, and the muscle transplantation procedure was done as a primary procedure for these people. Study area is RIO Bangalore. Patients with large angle horizontal deviations and patients who had given informed consent for the procedure was included in the study. And paralytic squint, FTT test, positive squint, and previous history of squint surgeries were accepted. So this is the pre-evaluation. As you can see, the case 1 had left eye suppression with a large deviation of 70 PD, exotropia. Case 2 had left eye suppression with 70 PD esotropia. Case 3 had right eye suppression with 70 PD exotropia. So this is the surgical procedure. If you consider a case of exotropia, usually you do medial rectus resection and then you do LR recession. But in this case, the resected part of the medial rectus, as you can see, which is shown in yellow color, is attached to the lateral rectus to cause a lengthening of the lateral rectus, and this causes further weakening of the lateral rectus. So here we are marking the amount of muscle to be resected. We are using a 6-0 vicryl suture to stabilize the muscle, and then you are cutting the medial rectus. So the stump which we get, the MR muscle, is kept aside in saline. Then we go to the LR side. So we are using a 6-0 vicryl suture again, and you're cutting it at the insertion site. So the stump of the muscle which we have kept aside, the MR muscle, we are going to do an end-to-end anastomosis here. And finally, we are going to use 6-0 vicryl to suture it to the new insertion site. So this is the same thing on a clay model. So this is the case 1. As you can see, she had a large exotropia. Post-operatively, it's ortho. So this was case 2 with large ESO. So results, case 1 and case 2 was orthotropic, whereas case 3 had residual 10 PD of exotropia. So usually for large angle deviation, we can either do a 2 eye surgery, or you can do a supra-large recession and resection, or you can use a botulinum toxin. But in this case, why our technique is better than the other techniques is it does not restrict the ocular motility, and it avoids resurgery. You can only operate on the non-dominant eye, so you're avoiding surgery on the dominant eye. And you can leave the other eye unoperated for any further additional surgeries. And there is no restriction of movement. So we can consider this muscle transplantation surgery as a good alternative primary surgery on a non-dominant squinting eye in case of large angle deviations. Thank you.
Thank you for the nice presentation. What did you take as large angle? When you say large angle, what do you mean by large angle?
Large angle is more than 70 PD, and very large angle is more than 70 to 80 PD.
No, traditionally large angle is taken more than 50 prism diameter.
PD.
So my point is, if you have taken more than 70.
No, we have taken more than 50 PD, but all of the cases were having 70 PD of deviation.
But you've taken more than 50.
More than 50.
Point is, if you are, what was the visual acuity in both the eyes in these cases?
It was a sensory exotropia. One was like hand movements, other was fine, 6/8.
One was sensory, so other one?
Other was 6/18 to 6/24.
6/18 to 6/24. So the visual acuity in both the patients was not appropriate. If you have had a sensory deviation, then we must anyway do surgery on one eye only.
One eye.
So in sensory deviations, it may be all right, but at the same time, the issue is that you are resecting the muscle all right. So if it is going to cause a restriction, so the restrictive force will be there, isn't it? MR you have resected put to the, LR you have resected put to the MR. So that restriction part you cannot eliminate. Of course, you have lengthened the muscle, and this muscle which gets, it will not be easy for this new muscle to get the vascular supply properly and the nerve supply. There is going to be, because the extraocular muscles are very heavily supplied by the nerve supply, and the vascular supply is also quite high because they are very metabolically active structures like CNS. The optic nerve, the extraocular
It was a myopia case. High myopia.
High myopia, then that myopic strabismus has again lot of issues in myopia and strabismus, because you can go from ESO to EXO to all those issues of heavy eye syndrome and SR and LR getting separated, and you have to do myopexy. So I wonder if there was no such thing. You showed some photographs, but these things you should have highlighted that this was a sensitive deviation and this was a strabismus exotropia with high myopia. But those high myopes who go for myopic fixers, they are quite often esotrope. Here you had an exotropia.
Exotropia and
Large
anisotropia.
exotropia. So that can happen. Myopia can give rise to all kind of.
But the anastomosis works well, sir. If we take the medial and put it to lateral, so the vessels and the nerve, they mingle well.
Maybe, see, probably there have been no studies on post-mortem on these. Maybe animal models, if they are there, have this.
Animal model it was.
Blood supply. I'm not.
It was done in 1973, sir. They have showed that it has remained viable, the stump, but it has undergone fibrosis. So it acts as a tendon basically, not like a muscle.
That's what I was saying, that it actually works as a tendon because it is like a dead tissue which is there, sort of an interface. So that part we have to take into account. So maybe
Structurally there, but not functionally.
not functionally. So even if you recess a large amount or hang back or something,
It will give the same.
it will probably give the same, and probably there have been no large randomized controlled trials on this to prove efficacy of one over the other. There have been short
Yes.
few cases people have reported, and you are saying it was reported in 1973. So that
1917 animal model, and recently in 2017, Jatani et al. Had done a 22 case series in Arvind, Pondicherry.
I'm aware of it. I'm aware. But that, he was presenting, I put the same thing to question. Anyway, so this is interesting, but we have to take with the baggage it has. So it may be advantages in sensory deviations. It needs to be proved with future studies. But otherwise, if you have large deviations, go for 3 muscles or even 4 muscles, because you also have to maintain commutance. You also have to maintain the peripheral pressure, because if you do large surgery on one eye, the peripheral pressure can also undergo change. So patient will be, you might have corrected this strabismus, but he will say cosmetically he or she will be very much disturbed, and a young girl will be really bothered. So that aspect also has to be kept in mind. Thank you so much.
Thank you.
Thank you, sir. Dr. Divya Vitala.
But she is not this thing.
Kusmita Chaudhary.
She is not ratified. So this is not.
Good.
Yeah.
Dr. Lakshmi Nirvan. Dr. Lakshmi Nirvan, if you can go there, be ready.
Good morning.
नहीं, भी नहीं. Divya Vitala भी नहीं. Even if he's नहीं. मतलब you submit it and then you select it and then you don't answer. You should be organized करना.
Yes, Dr. Shilpa, please start.
Good morning. I am Dr. Kusumita. In the next 5 minutes, I'll be taking you through an interesting case of myotonic dystrophy that came to our OPD. No financial interest disclosed. So, a 42-year-old male patient presented to our OPD with chief complaints of decrease in vision in both eyes, which progressed gradually over 6 months. Along with that, he complained of drooping of both upper eyelids, progressing since last 2 years. On external examination, the patient had severe blepharotosis in both the eyes with MRD1 of 0.5 millimeters. The lid crease was absent, there was no lid lag, and LPS action was 4 millimeters. Further examination showed that there was no diplopia. Cover-uncover test showed orthophoria. Patient had on ductions and versions, he showed no movements in any gaze in either eye, giving a frozen globe-like picture. FDT showed restrictive pathology. Best corrected vision in both eyes was 6/12. Pupils reacted normally to light and accommodation. Other than bilateral cataract, which was nuclear sclerosis and posterior subcapsular, rest of the anterior segment was normal. Gonioscopy showed open angles in all 4 quadrants. IOP was 18 millimeters mercury. Posterior segment examination showed syncytial scintillance in the right eye. Both eye discs had healthy NRR with a CDR of 0.3, and the rest of the retina was within normal limits. Other than that, he had typical features of myotonic dystrophy. Patient had hatchet face and swan neck, attributed to the wasting of facial and sternocleidomastoid muscles. He had proximal muscle wasting, dysarthria, frontal baldness, which are the classical symptoms described by Hans Steinert, distal myotonia of the thinner muscles, and gait disturbances. He underwent MRI of the brain and orbit to rule out involvement of the gaze pathways. ECG was normal, and blood test gave normal thyroid function tests. Now, looking at the various differential diagnoses, we considered myasthenia gravis, but which was unlikely as there was no fluctuation or fatigability of hystosis or ophthalmoplegia. Thyroid orbitopathy was ruled out as there were no lid signs or exophthalmos. Myositis was excluded due to absence of pain or inflammation. Chronic progressive external ophthalmoplegia are a group of disorders with symmetric bilateral painless progressive pupil sparing ptosis and ophthalmoplegia. However, distal myotonia, wasting of the face and neck muscles are prominently absent. Kearns-Sayre was ruled out because it has an age of onset before 20 years and is associated with pigmentary retinopathy, cardiac conduction abnormalities, and cerebellar ataxia. And oculopharyngeal muscular dystrophy is another CPO-like disease with nuclear DNA mutations, unlike mitochondrial DNA mutations in CPEO, but complete ophthalmoplegia is rare. Myotonic dystrophy, also called as Steinert disease, was described by German physician Hans Gustav Wilhelm Steinert in 1909 as a classic triad of proximal muscle weakness, dysarthria, and frontal baldness. Ophthalmic signs of cataract, which is classically described as Christmas tree cataract, ptosis, and ophthalmoplegia were described later. Its genetic basis was described in 1992 and has some interesting points worth noting. It is autosomal dominant inheritance associated with dystrophia myotonica protein kinase gene in chromosome 19. It is associated with trinucleotide CTG repeats, and the phenotypic expression depends on the number of repeats. So less than 34 repeats may be asymptomatic, whereas more than 50 repeats show full manifestations. It shows the phenomenon of anticipation, which is in the subsequent generation, the disease manifests earlier and with more severity. Myotonic dystrophy is a debilitating multisystem disease with no known cure, with wasting of facial and neck muscles, proximal weakness, and distal myotonia. Involvement of the respiratory system leads to fatal complications. Classic myotonia dystrophy presents in the 3rd to 4th decade, and ophthalmic manifestations are telltale, preclude other symptoms, and provide clue to early diagnosis, and include posterior subcapsular cataract, ophthalmoplegia, ptosis, and the typical facies. Lab confirmation can be done by looking for the CTG repeats. Thank you.
Thank you, Dr. Very
Thank you, Doctor.
interesting presentation. It's a rare condition, and you have not done any genetic studies on this.
Sir, unfortunately, we could not do the CTG
So the
repeats.
diagnosis is
It's more or less clinical.
presumptive because
Yes, sir.
we don't have genetic analysis. It is presumptive, but what is important is to consider these kind of possibilities when you are dealing with some kind of patient who is not fitting into classical picture. I remember one IDO case is long ago, maybe 20 years back, and it was described by primary geometric overreaction and cataract and this and that, and retinitis pigmentosa. And when I looked
Christmas tree cataracts.
Christmas tree cataract. He has read about it. So there is a Christmas tree kind of cataract. If you find that, not in all the cases, it is a posterior subcapsular, but some of these may possibly have a Christmas tree cataract. So that is very diagnostic of marginal dystrophy. And what is important is that there is paresis as well as stiffness. So if somebody shakes hand, he will not be able to relax. Once he shakes, once he is able to put that much of energy, he cannot withdraw that. So stiffness is very important aspect along with paresis. It's like Duane syndrome, that you have a paresis as well as restriction. So both things in different combination. We have a very wide ranging presentation. So it will be always you have to keep that spectrum of presentation in mind and then look at the differential diagnosis. Other things important, of course, will be anything can be present with an ophthalmopenia, particularly muscular dystrophies, as you rightly said, because there was a very gross wasting of sternocleidomastoid in this, which was very prominent. So this only happens in either muscular dystrophy or myotonic dystrophy. So that is one thing. If you find that swan-like leg and long face, then you should think of muscular wasting. Look for facial low function, because there you may find that the facial low function is affected. Strabismus may be there of all kinds, depending upon the variability of paresis and restriction. You may have a strabismus, which can even go ESO, may go ESO. And usually they don't complain of diplopia because these conditions are coming up slowly. As you rightly said, they present during second, third decade. And myotonic dystrophy 2 may even present later. That is milder form. And there is a phenomenon of anticipation, as we rightly pointed out, with autosomal dominant disorders, that the next generation, because there is accumulation of these TPD abnormalities, so next generation there is chances of early presentation. All of us have some of these TPD repeat deficiency, but if it is more than, I think, 90% or 20%, some percentage, then only is going to manifest. So it is something which happens to all of us, but in much smaller scale. Once we cross that particular figure, we start having symptoms. So anything, anybody want to ask anything? So visual acuity, motility, optic nerve function, this pallor, and of course pigmentary changes that we should, as far as we are concerned, and systemic involvement of the respiratory system, cardiac issues, because they are the life-threatening issues. And a good number, there is very little treatment. So a good number will need support, ventilatory support and all those things. There is not much treatment is there, so that is further like our domain, that will go to the physicians and the cardiologists. But as far as we are concerned, patient may come to us first, so we need to suspect, diagnose, and refer the patient for further treatment. These cataracts by and large don't need surgery because they are not so dense, call for surgery by and large, of course. Thank you.
Thanks.
Thank you, doctor. A good one. Yeah. So keep in mind this kind of presentation that is there. Because if you don't suspect, you will not know. There is saying that eyes only see what mind knows. Or the brain is only able to, is prepared to interpret what the eyes only brain is only prepared to interpret what eyes, the eye only sees what brain is prepared to comprehend. This is said by Vincent. He was a French philosopher. Okay? The old adage. Thank you. Next one will be called.
Yes, so we have Dr. Lakshmi Nirvan here from Nagpur.
Yes.
Yeah, good. Welcome, Dr.
Thank you.
You should become a member, Dr. Lakshmi, and you too, Dr. Bhavya, so that you are eligible for the award that they have. You have good presentations, but I'm sorry we cannot mark you.
And also become members of the Squint Society, all of you. If you are interested in Christmas, you should also become a member of this OC. I'm the secretary, so you can all apply and become members.
Good morning everyone. Myself Dr. Lakshmi Nirvan from AIOCMTC Nagpur, Junior Resident 3. Thank you AIOS committee for giving me this opportunity. My topic of presentation is evaluation of alignment of visual axis and its psychosocial effects before and after surgery in concomitant horizontal strabismus. No financial disclosure. Strabismus, also called as crooked eye, it is the condition where visual axis of the two eyes do not meet at the point or object of regard. Esotropia is the manifest convergent misalignment and exotropia is the manifest divergent misalignment. Now, why we are doing this study? The estimated pooled global prevalence of strabismus was found to be 1.93%. In India, the overall magnitude of strabismus was 6.9%, and among them, 3/4 were of concomitant strabismus. Bradley Nelson et al. Observed that such patients may develop mannerisms such as lack of eye contact. Also, they may have negative impacts like negative self-images, poor interpersonal relationships, and problems regarding their schooling, work, play, or sports. There are very few studies where alignment of visual axis and psychosocial effects after surgery combinedly studied. Aim of this topic is to evaluate alignment of visual axis and psychosocial aspects after horizontal strabismus surgery in patients with horizontal concomitant strabismus. Inclusion criteria: patients above the age of more 12 years with concomitant esotropia and exotropia. Exclusion criteria: patients with paralytic strabismus, restricted eye movement with oblique muscle involvement were excluded. Coming to procedure, detailed general history was taken about the age of onset of deviation, any significant birth history, any orthoptic treatment taken or surgery done. Photos of patients since birth were collected. Rest, detailed ocular examination was done. For squint examination for evaluation of motor status, maximum angle of deviation was measured by prism bar cover test, and in patients with deep amblyopia and very low vision, modified Krimsky's corneal reflex test was used. For evaluation of sensory status, Workford dot test, diplopia charting, and Lang to pencil test was used. Coming to psychosocial assessment, all participants were given the standard adult strabismus 20 questionnaire pre-operatively, which was converted to their local language, that is Marathi and Hindi. This AS20 consists of total 20 questions, 1 to 10 from psychosocial subscale and 11 to 20 from functional subscale, and each question were given the 5-point type Likert scale was used, and this question was converted into the Marathi language. These patients were subjected to either resection or recession surgery or both resection or recession surgery. Coming to observation and results, patient's mean age was 21 plus minus 7 years. We divided the patients into two groups, group 1 esotropia including 12 patients and group 2 exotropia including 18 patients. Successful surgical outcome was considered as angle of deviation of less than 15 prism diopter. At 3-month follow-up, it was found that mean preoperative angle of deviation was reduced from 44 plus minus 10 to 12 plus minus 2 prism diopter. As we can see that in esotropic patient, 75% patient had orthophoria and 25% had residual deviation. Similarly, in exotropic patient, 78% patient had orthophoria and 22% had residual deviation. These are the preoperative and postoperative images of one of our patients with successful outcome. This is another example. Coming to result of psychosocial effects, median overall questionnaire score ranges from 0 to 100. In our study, it was found that preoperatively the score was 56, which significantly improved to 92 in patients with successful surgical outcome and up to 78 in patients with residual deviation. These are patients with esotropia. These are patients with exotropia. Out of 7 patients with residual deviation, 4 patients were reoperated later on dominant eye after 6 months with successful surgical outcome, and remaining 3 denied the reoperation. Coming to discussion, Celebi and Kuchner in their study of large angle deviation observed that monocular strabismus surgery is recommended procedure, as this procedure minimizes the handling on dominating eye, reduces the surgical time, and reduces the fear of patient. The successful outcome of present study can be compared favorably with the results of studies in Maharashtra by Dr. Parikshit sir et al., in Hyderabad by Dr. Samin sir et al., also with Thai study, Turkey study, and Brazil study. This is the comparison of second surgery done on dominant eye in patients with residual deviation after 6 months, showing similar results as present study. This is the Mayo Clinic study considering the AS20 questionnaire for psychosocial assessment in adult patients after strabismus surgery, showing similar result as my present study. The surgical intervention restores binocular vision, rectifies 3-dimensional vision, broadens the visual field, improves head posture, and improves psychological status and cosmesis. Concluding, surgical correction resulted in restoration of alignment of visual axis in 76% of patients, and bilateral surgery resulted in further restoration of alignment of visual axis in 13% of patients. Same eye recession produced better surgical results than bilateral recession. Restoration of alignment of visual axis resulted in improved psychosocial adjustment and functional concern of patients. These are my references. Thank you very much.
Thank you, Doctor. Thank you. Very nice presentation. But one thing is that you described psychosocial effects. You did not compare with the preoperative to post-surgery. Was there any change in what psychosocial implications patient had earlier and what he had after surgery, which quite at times was not appropriate, as you rightly saying?
patients with residual division, residual division, we calculated the mean score of psychosocial aspects.
But it will take preoperative psychosocial score, because that will be important to see how happier they felt before what they were feeling earlier. And residual doesn't always mean it also gets overcorrected. I'm sure you have had some overcorrections also.
Sir, out of 30 patients, there were no any patients with
That
correction.
means you were already targeting under correction, I would say, because nobody was overcorrected. So that means you were targeting under correction only. So that is not a good, always good approach, because these deviations after some time they will increase and get back to what they were. In exo deviations, you do surgery on two muscles. Many people operate on one eye in large deviations, and they say other eye we will operate later. A two-step approach. But that is not the right thing to do, because this deviation is going to increase beyond 6 weeks, even just 6 weeks, and you will be back to what you had initially. So it is not always try to correct the deviation, rather undercorrect, and try to operate on both the eyes as far as indicated. Like of course sensory deviation you should not operate on both the eyes, there is no reason. Because brain works by balance. Your right hand, your left hand, your right foot, left foot. Same way eyes. Because there is a binocular wiring in the occipital cortex. So if there is imbalance, brain is not activated. You may have monofixation and all those issues. There could be a V pattern, there could be a pattern strabismus, there could be lid aperture changes. So all these issues should favor that you do a bilateral surgery as far as possible, rather than do a large surgery on one eye. But once you resect a muscle, resection effects are there, bit of narrowing, bit of limitation in opposite case, until you have done a very small resection, which usually in these cases will not be there because your angles were large, I think. So in those cases, probably it will be better to do a bilateral surgery, and then I think you have should have, and then you took 15 prism diopters of residual deviation as successful.
Yes, sir.
Okay. You cannot treat 15 prism diopters as a success. It doesn't make much logic, because as we know, you can fuse about 8 prism diopters in horizontal line and about 2 to 4 prism diopters in the vertical axis. So 15% can't fuse. So if it is undercorrected, you will have this deviation. It may not be very obvious to some stranger. He might say, "Ah, you are looking better," but actually he does have the deviation. So that will still have those effects, and as I say, slowly is going to increase. EXO and ESO obviously may remain well, but then it will need further surgery. So had you planned earlier properly, you would have probably done more appropriate surgery and lesser undercorrections. Because your undercorrection rate कितना था तुम्हारा इसमें? How many you undercorrected percentage wise?
Sir, out of 30 patients, 7 were patients with residual.
Out of 37 were residual in ESO or in EXO?
23%.
In EXO or in EXO?
4 patients in exotropy and 3 patients in isotropy.
So your undercorrection rate will work out about 30%. 24, 30, 25, whatever. So that is quite high. So in today's world, there are a lot of issues. Patients are very demanding and commanding, and they want to have perfect alignment, as if they were nature produced them in a perfect way. And anybody who is imperfect in any way, they are very aggressive and they're quite disappointed and unhappy. So, and as you rightly said, there are a lot of psychosocial issues. So we should try to give them best chance in the first sitting. I think that should be the effort. So this is an interesting study, but I think in exo deviations, if you don't assess them properly, so you will end up with undercorrection. So one thing you should keep in mind, that intermittent exotropy and changes the time I think will come.
No, we'll also take a picture with all the centers.
So since we have time, we can just talk 2 minutes, I think. So in exo deviations, what is important is they are more for undercorrection. Why? This is also called, we were born bilaterally, we were born as lateral eye diagonals. The eyes were placed here, above the ears. Okay. Slowly, our eyes moved forward and we became binocular. Now we
area, lot of predators. So our ancestors, means apes, they climb the trees to avoid lion on the ground. So when you go to the tree, you have to be very precise. Your vision has to be very good. You have to have very good depth of perception, because if I have to branch from this branch to that branch, I need very good visual acuity. I need very good proprioception of my my rest of the muscles of the body. I need very good cerebellum to be able to translate that, how much force has to be given to biceps or to your gastrocnemius, whatever. So that has to be very precisely calculated. Same way आपका psyche वगैरह, because the vergence has to be very important. So a lot of brain's efforts, about 60% of brain's input is from the eyes in human beings and our great apes like chimpanzees. Because we share about 95% or maybe more of our DNA with, probably 99% DNA we share with chimpanzees. We are just 1% different from a chimpanzee. So for this we needed depth of perception and stereopsis. Because leopard animal, he had one eye going to this part of the brain, this eye going to this part of the brain. Large panoramic vision. They see everything. Even their back, if somebody is coming, they can see.
All the herbivores, those who want to run away from predators, so all the deer, the cow, the buffalo, even most birds, they have eyes on the side of the head, so they can see 360 degrees. But all the organisms which depend on distance depth judgment, which is all the hunters, so all the tiger, the lion, the panther, in the birds, the vultures, the eagles, they have their eyes on the front of the face, because then you get best distance depth.
Yeah. So with that, what came, that we had strabismus. There was no strabismus as we were that eye. There was no need for strabismus, because this eye is in this, by going to this brain, this eye going to, there is a cross. Why there is crossing in the brain? If why should optic nerve of this side go to the opposite side, or vice versa, or it should not go? What do you think makes sense? This eye optic nerve should go to this side of the brain. This eye should go to this side of the brain. It makes sense, perfect logic. There is nothing wrong. But unfortunately, there is total crossing of eyes. So there was a total chiasma. We got into a half chiasma to get binocular. So we have the retrograde thing.
आज और